Hello, everyone. Welcome to our Grand Rounds. Today, my name is Larissa Mooney. It is my great pleasure and honor to introduce our speaker today, Dr. Tom McLellan. Dr. McLellan has been a career researcher and leader in the addiction field, serving in numerous roles, including founder and chair of the Treatment Research Institute, a nonprofit organization dedicated to science-driven reform of treatment and policy in substance use, and professor of psychiatry at the University of Pennsylvania, Perelman School of Medicine. Dr. McLellan served for 2 years as the Deputy Director of the White House Office of National Drug Control Policy and a senior author of President Obama's National Drug Control Strategy. In 2016, he served as senior editor for the U.S. Surgeon General's report, Facing Addiction. He was the principal developer of the Addiction Severity Index, the ASI, and the Treatment Service Review, widely used instruments in substance use disorder research. Dr. McLellan has received Lifetime Achievement Awards from the American, Swedish, Italian, and British Societies of Addiction Medicine, and jointly from NIDA and IAAA. I've had the personal pleasure of meeting Dr. McLellan in Egypt some years ago, where we presented at the University of Cairo for UCLA ISAP's former Fogarty training program. As a visionary in the addiction field over the course of his career, we are truly honored to welcome him to our UCLA Grand Rounds today. He will be presenting on the concept of pre-addiction that has generated lively discussion and some strong opinions among our colleagues. So it is a ripe and timely topic for today. Welcome, Dr. McLellan.
Thank you very much, Larissa and everyone. So without further ado, I'll share the screen here. And so let me first tell you, first of all, I'm very happy to do this. And let me tell you what you're not going to hear today. I'm not going to give you results of a randomized controlled trial. I'm not going to do a systematic review of a lot of research. This is a conceptual talk, and it's simply one suggested way of doing something that I, at least, think is very important. That is to move the recognition, diagnosis, and treatment of substance use disorders further ahead, move it earlier in its course. And I'll go into why that is. So I won't be speaking for long. I'm going to be quite happy to take questions, and all of these slides are available either through me or through UCLA. So first, let me disclose some involvements. I'm happy to say I've been on the board of Indivior Pharmaceuticals, Groups Recovery, and Shatterproof. I will not be speaking about any of the products or services that are provided by any of these today. Okay, so let's start off by saying something that I hope isn't provocative. I hope this will be accepted. I take no pleasure in saying it, but addiction field, and particularly the treatment of it, is in trouble. It's not doing well. From its inception, there has only been a treatment system designed for the addicted. Very importantly, you weren't eligible to get into treatment, at least the specialized treatment programs that are made up the bulk of treatment in this country for now 5 decades. You weren't able to get into that unless you met criteria for being seriously addicted. And in turn, that has produced stigma. Nobody decides one day, you know, I don't think I'm being all I can be. Maybe I'll go to addiction treatment. That simply doesn't happen. Most people are forced into it. having failed numerous other efforts to control their substance use. Consequently, they're very low penetration rates. Maybe there's 20% of those who meet the criteria of serious addiction. Maybe 20% are in treatment these days. And in comparison, the next worst penetration rate is depression, with over 60% of those who meet diagnostic criteria for major depressive illness are in treatment. So people haven't wanted to do that, to get into treatment. So they delay treatment until their condition is really quite severe. It's usually chronic and usually has a poor prognosis. It is rare to find a person with an addiction treatment that doesn't also have at least one or more physical medicine or psychiatric conditions that further complicate their care. Once in treatment, adherence rates are very low. They're comparable with other chronic illnesses, but it's very, especially in outpatient treatment, it's very difficult to sustain participation. And once treatment ends, regardless of how it ends, relapse rates are in the neighborhood of 50% within a year, and about 90% of annual relapses occur within 90 days of end of treatment. So it would be my summary that things ain't going so well in the addiction treatment field. People don't want it. If they get into it, they don't adhere, they drop out early, and they relapse. So that's not good, but it's also not unique. There are a number of illnesses where similar kinds of problems have occurred. The most notable is type 2 diabetes. And this is my summary. By the way, I didn't say this, but I will try to tell you when I'm giving you essentially factual or at least verifiable information. And I'll tell you when what I'm saying is my opinion. So this is verifiable information. And around circa 1995, the diabetes field also was focused on very severe diabetes. Once again, there was resistance to entering treatment. It was essentially an admission of guilt that you hadn't controlled your diet and exercise and everything. And so people delayed entry until they had very serious conditions. In 1995, over half of all amputations in this country were due to the progression of the illness of type 2 diabetes. Once again, poor adherence to the available medications and diet and exercise regimens, and generally very poor outcomes and very high costs. However, even in 1995, and actually before, it was possible to recognize and predict those who early on were most likely to go on and develop full-blown type 2 diabetes. You could do that with background, family history, and common lab tests. And the reason that's important is that around that era, the American Diabetes Association, I really want to underline this. American Diabetes Association is an advocacy group that speaks for, represents, tries to develop policy, tries to keep in the public's attention patients and their families with diabetes. And it was that organization, not researchers, not clinicians, not politicians. It was the American Diabetes Association who, around the turn of the century, coined the term pre-diabetes. And they did this based on the research reports that it was possible to identify those early in their their career who were likely to go on and develop it. And they had a very, very targeted, very purposeful strategy in mind. And the term pre-diabetes was purposely selected rather than, let's say, early indication of hyperglycemia or early indication of mild to moderate glycemic control. They wanted something that was very clearly understood by the American public and American clinicians. They wanted something that was frankly pejorative. Nobody wants diabetes. Everybody knows it's a bad thing. So it was designed to have an emotional content and a motivational content. And all of that was designed with other parts of the strategy to move the recognition and care of this illness way earlier. So with their coining of the term, they called upon laboratory researchers to develop a true, accurate operational definition of this term. They called upon and spent a lot of money on a public information campaign, letting the public know that type 2 diabetes was not inevitable, that there was a run-in, that it could be avoided. They were very eager and very strong in changing curricula in medical and nursing schools. There had been no discussion of that before, very little discussion of that before. And very importantly, they went directly to insurers and said, look, it is in your interest to identify this early. If, and a big if we can identify it, if we can develop new treatments and interventions, we could save you some money, but you'll have to support it. We need your help. And in turn, they called on the NIH to develop new interventions. The point here, don't lose the point. Point is that all of those things followed the creation of the term, and in turn followed the strategy of the American Diabetes Association to move treatment forward. Oh yeah, so what? Well, by 2022, by today, nobody can say that type 2 diabetes is cured. No way at all. It remains a very serious and pervasive illness, but there have been really remarkable changes. Much improved screening and risk detection. These are reimbursed clinical events. They are taught in medical and nursing school. Competent clinicians know how to do that, and they expect to do it. And that in turn has led to much earlier treatment entry, higher penetration rates, and that in turn has been because there have been new diets, new behavioral interventions, and new medications, and sometimes the use of older medications earlier in the course of care. And that has improved treatment penetration rate. It's now up around 70%, and far less progression to full diabetes. That's interesting. I'll just flash this slide up. About April of this year, there was a very nice research review in JAMA by a very esteemed researcher from Johns Hopkins. I say he's esteemed because that allows me not to say this man's name. But anyway, some points along the way. There's not one simple, clear definition of prediabetes. There are actually three. And there is not yet consensus of which one is best. It's very clear that not everybody who meets criteria for prediabetes, regardless of what it is, goes on, but 10% per year go on. However, with available treatments, that reduces to half of that, all right? And the effective treatments thus far are lifestyle changes, weight reduction, semaglutide, metformin, things like that, that you're hearing more and more about. And the key is those things are being applied earlier when the condition is still not chronic, not severe, not loaded with additional diagnoses. And so I said, and my colleagues, Nora Volkoff at NIDA and George Poop at NIAAA said, I wonder if a similar kind of strategy could work in addiction. And we wrote an article and sent it to a number of journals, and the answer came back very loud, very clear. Hell no, there's no way. What are you kidding me? You just don't seem to realize that diabetes is a very different illness than addiction. Pre-diabetes is not simply a sign, it is itself a very serious health condition associated with lots of morbidity. It won't work in addiction because in diabetes, there are already proven reimbursed treatments, and they're very good lab tests that define and predict diabetes. We ain't got none in the addiction field. So, okay, those are fair points, and they were raised by reviewers in a number of these when we sent our articles. So let's go through these. And again, I'll tell you what's fact, and I'll tell you what's my opinion. And the first thing is, it is true that it's not debatable that diabetes is very different, much better characterized, got a whole different pathophysiology than any addiction. But that ain't the point. Of course it's different, but the problems that were faced by that field are very similar to the problems currently and throughout my career that have been faced by the substance use disorder field. And so the question remains, despite the fact that we know the illnesses themselves are different, could parts of the kind of strategy that we used to move care earlier in type 2 diabetes, could they have some benefit? Could they be implemented, and could they have some benefit in the substance use disorder field? Here's another very reasonable comment. But what has missed is substance misuse, the subdiagnostic or early signs of what later becomes a substance use disorder. They too are a very serious public health, clinical and public health problem, accounting for substance misuse, low level but problematic use of alcohol and any of the other substances of abuse, account for 28% of college rape and interpersonal violence cases every year, 44% of injuries among those most at risk, teenagers to early adults, 63% of all the disabilities that occur among our young people, 3/4 of all the deaths. And while these figures are extremely high, and you can see the background research in this in the Surgeon General's report of 2016, hasn't changed. Despite how bad all of this is, it's even worse for minority communities. So the point is that substance misuse is not simply a lot of partying. There are very significant problems that accrue even before you get into the serious disorder category, okay? Another important caveat that said the reason these kinds of strategies won't work when substance use disorders is that there are good treatments, good diagnostic tests, etc. But please remember that while that is true, most of those followed the coining and popularization of the concept itself. It was the concept that moved the field. It wasn't the field that generated enough information for to have the concept. NIH grants developed as a public, Congress demanded it, NIH responded very well after the concept was defined. And only once the term prediabetes was coined were insurers willing to try it. It made sense to them. And they said, yeah, we'll give it a whirl. We will reimburse and pilot test previously unproven, but potentially valuable kinds of care. And so it came to pass. It's widely said that we don't have a biological test for addiction, and that is the truth. But there's also still no complete consensus on lab tests for diabetes either, prediabetes either. There are 3, and they all have a different contribution. There is not yet a consensus. If you read that review article, you'll see that. Also, none of them are 100% specific, meaning that it's not clear that patients who meet prediabetes will definitely go on to develop type 2 diabetes. In fact, only 10% per year go on. But prediction with any of the available tests is about 70% accurate. Prediction is possible, and prediction is possible in the addiction field very easily, not with a single test, at least not yet, but a simple combination of family history of addiction, family history of or early indication of mental health problem, and recent self-report information on type, frequency, and amount, intensity of substance use are very good predictors of at least the potential for progression into full-born addiction. So, all right, Tom, maybe you got something. It's a pretty good argument that we need to move the field forward. Okay, our field doesn't have to be perfect in order to do that, but where would you start? Well, Doctors Volkoff and Koob and I are suggesting that as an initial, a to be tested definition could be the DSM, existing DSM-5 symptoms, just 2 to 5, now mild to moderate. They are empirically derived, they're very well tested, they're easily collected in a lot of different settings, but I don't know how many, I don't know how fast, I don't know even whether those with 2 to 5 DSM symptoms will go on to develop 6 to 12 symptoms. I don't know that. To my knowledge, not many people do. That's the kind of research that's needed. And if it's not been clear to you, one of the reasons for me to take up your time with this talk is to urge this kind of research to go on. There are data sets that would admit to this kind of question. And it's at least one starting point. All right, wise guy, how many would that be? This is a pyramid that illustrates American substance use problems. The great majority of Americans above 12 years of age don't use substances at all. If you see that wavy line there, that's where misuse starts. The solid line is where you meet the diagnosis of severe addiction, and the top pinnacle there, the bright red, is the proportion that are in treatment. Not a pretty sight, as a matter of fact. But if you said let's see if mild to moderate substance use criteria would be indicative of pre-addiction. That would, according to the available data, about 15 million of those who are misusers who meet 2 to 5 criteria might qualify for this still hypothetical term pre-addiction. Yeah, okay. So what? What would they get? Well, candidly, the only thing that we could find in the existing literature that has been shown to be effective as an early behavioral intervention is screening and brief intervention. Much better for alcohol than for other substance use disorders. Notice I didn't even put the RT on it. SBIRT simply has not worked. It's people who meet early diagnostic criteria simply refuse to go and get referred to existing addiction treatments. Probably correctly, because they may not qualify, they may not be that severe. However, while brief interventions can be very effective, they aren't a snap. It's not just encouragement to stop drinking. It's a very subtle, sophisticated clinical technique that involves training and sophistication in a therapist. So I'm not sure that this kind of thing will fit into primary care or school clinics, et cetera. Cognitive behavioral therapy, family couples, other kinds of therapies have also shown promise, especially among those earlier in their substance use trajectories. But to my knowledge, there has been no concerted effort to try and look at any of the behavioral interventions, with the exception of behavioral brief intervention, in those that do not qualify for an addiction yet. As was true in the case of diabetes, it may be true that some of the existing pharmacotherapies that have been pretty good in treating seriously alcohol and other drug-dependent individuals, they may be far better in people with lower level problems. Best example, there are a number of studies now suggesting that naltrexone reduces binge drinking, holiday drinking, and heavy drinking among college level misusers. So I would call that, it is my opinion, that that's an avenue that is worthy of consideration. Maybe a camprosate, maybe there are other medications that are potentially useful in reducing these early signs of loss of control. Been very interested, again, turning to the diabetes field. If you've followed the meetings, this year's meetings, the big findings were that these weight reduction medications, semaglutide and others, also had, they didn't just alter the metabolism of sugar and produce weight, they reduced craving for food. So there are a number of studies in the addiction field with these and other medications that suggest that at an early stage, before craving becomes really profound, some of these medications may have a role in reducing craving and compulsive use. And then there's an entire set of interventions that are more and more popular. Internet coaching, support programs, Noom, other virtual programs have been successful. I've not seen research evidence of it, but they're commercially successful, meaning a lot of people are trying them to manage early stage weight loss, early stage drinking, early stage computer gaming, other things like that. So I simply leave open the possibility that these are avenues that researchers in our field might want to pursue. So there are other problems in our field, though. I return to that early slide about the genesis of the term pre-diabetes. It did not come from researchers, didn't come from policymakers. It came from public advocacy, and we ain't got no public advocacy. Never have. There is no organization that speaks for patients and their families. And that could be an impediment to advancing earlier care in the addiction field. I have to simply say, these are not pretty words, but ignorance, prejudice, and time constraints among primary care physicians are endemic, not just in addictions, but I'd have to say particularly in the addiction field. I thought the advent of HIV would get primary care involved in the addiction field. Hardly. I was certain that the opioid epidemic finally got the attention of primary care and general medical care. I ain't seen it. I don't know what is going to get the attention, despite the fact that if you turn over, this is not my opinion, these are facts, you turn over any expensive, particularly chronic illness, you will find early signs of substance use. So it has always been in the interest of mainstream healthcare to pay more attention to substance use, but they haven't. And I don't know what will do it. And then it's the public too. So many in the public continue to think that substance use problems have a special place. I must get at least 2 a week. People calling me saying, you know, I have a friend who, I have a cousin who, I have a nephew who has a problem, and they want treatment, they want a recommendation. They always end their request for the recommendation with the proviso. Tom, I just want you to know, this kid comes from a good family. You know, he's not a derelict. He's not stupid. And I often think to myself, when somebody asks for diabetes treatment or hypertension treatment, they say, well, he really comes from a good family. I mean, the implication is really clear. The overhang is still there, that there must be something, quote, wrong with somebody who's stupid enough to become addicted. And it betrays a lack of public understanding and good communication on our part, researchers and clinicians and policymakers. So I'm not, in other words, I'm not trying to sugarcoat this is the way to move forward. I'm not naive, but I do think that it is at least one avenue that is warranted. It borrows directly from a strategy that has worked in a very different illness, but an illness that had many of the same penetration, adherence, and relapse problems as we did. I don't know if there are downsides to this, but that's important to study as well. Maybe this will, I've heard this from many of the reviewers of our article, there's concern that this will further stigmatize an already stigmatized group. I find that hard to believe, but it could be. I don't know if this, I do know that in diabetes, it was part of an overall strategy that got the attention of mainstream health to look for, diagnose, and intervene early. I don't know if that will happen here. And that's the point. these are important questions that have as yet not been answered. That's why they make research. That's why they make research grants. And if you're wondering, yep, at least NIAAA and NIDA are committed to advancing and broadening the kind of research, earlier kinds of interventions. So with that, I will conclude. You will be excused for thinking, geez, this guy didn't give me any answers at all. And that's right. I gave you mostly questions. So at this point, I'm quite happy to share the screen and answer questions if I can. Thank you again.
Thank you very much, Tom. Several accolades in the comments related to the fascinating nature of your talk and the important discussion. We do have a few questions that have come up. And one of them is about that advocacy issue that you referenced about. You said that substance use doesn't really have a group comparable that is providing advocacy as the Diabetes Association. There are groups like MAD, Mothers Against Drug Driving, and FAVOR, Faces and Voices of Recovery. And do you see them having a role in this discussion? And if so, what are your thoughts about that?
These are everything that follows is my opinion. I don't think this is factual. Well, my first thought is, so far, no, I haven't seen that they have had the kind of impact that I'm sure they wished for. Two, there's one of the problems that's I think been a bugaboo in our field is a distinction between an actively addicted individual, a person who has let us say completed a treatment program, and a person who is in stable recovery. I make a very big deal about those distinctions. I can talk about them. I've seen them every day of my life, but most of the public doesn't. They are unaware of just how pervasive and how effective recovery can be. I don't want to say most, way too many people who have relatives that become addicted or have a substance use disorder despair. They think that's the end of my relationship. They'll never get better. Nobody ever gets better. And that is factually wrong, but it hasn't, that's wrong hasn't yet penetrated much of the public or the policymakers, and neither has the what it takes to take somebody from active addiction to having completed or entered or completed care to stable addiction, to stable recovery. When that happens, I think there could be a real groundswell that would believe me, I'd be part of it as a person who with a lot of active addiction in my own family. I would really welcome efforts to advocate for more and better interventions to bring people into recovery. Sorry, that was an awkward answer, but that's the best I got.
Yes. Some answers are just awkward. I thought that was a great answer. That stigma issue that you brought up earlier, I think is a really important one. And the concept of pre-addiction, as you mentioned, has gotten some pushback because of that stigma issue. Given that when you look at some of the data that's been collected about stigmatized conditions around the world, addiction is the most stigmatized condition among the stigmatized condition. And that young person that you talked about who's, comes from a good family, they're not a problem kid, they're not any of those kids, is this concept of moving kind of sort of a diagnosis earlier, running the risk of decreasing the likelihood of them coming in because of that, you move that stigma earlier as well. What are your thoughts on that?
I have a lot of thoughts about that. They are all my opinions, and I'm sure there will be controversy, but in order. it's hard for me to imagine a situation that is much worse. And maybe it could be worse, but after literally billions of dollars in the last decade have been spent to bring more people into treatment, to make treatment more affordable and accessible, and penetration rates have crept up from 10%, 15, possibly 20% if you include AA. I don't know how much worse it can get, A. B, some of the worry comes from the harm reduction, the broad harm reduction community. I don't wish to characterize everybody, but let me just say that I am my personal view is I am for any harm reduction effort that also reduces drug use, because I know for a fact, not an opinion, that drug use and misuse is harmful. So while I'm for, all the medications and, I mean, it's crazy to me. Methadone, buprenorphine, long-acting naltrexone, et cetera. These are somehow considered harm reduction efforts. I'd call those medications. I don't know, but I'm not for the efforts to make life safer and easier for people who choose to continue to use drugs. Not because I want to punish them or send them to jail or any of that nonsense. It's because they're hurting themselves and because there are very different options. So I think I have heard from some in the harm reduction community that it would that's part of their worry, and frankly I just don't share that worry. And the final thing is this: isn't addiction itself a pretty pejorative thing? Yeah, it is. Diabetes too. It's no way to pick up sexual partners at a party, say, hey, I got a brand new car, it's a nice night, and I'm pre-addicted. Let's go for a ride. That ain't gonna work. And that's, to me, one of the important positive things about it. Everybody understands that addiction is a bad thing, just like diabetes is a bad thing. You don't want to get it. And it is hoped that the term pre-addiction conveys a moral and motivational and emotional meaning that says you better do something, Mr. Individual affected, but also Mr. and Ms. Clinician. It's time to do something. And so it's that. And sorry, I said that was the last. Do not confuse the term pre-addiction with addict. Addict, schizophrenic, maniac, these are pejorative terms. They don't have any value. You cannot name an individual with their illness, okay? But pre-cancerous, pre-diabetic, pre-addicted, etc., are adjectives designed to convey time for action. Long answer, hope that was a little better.
I'm going to move to the issue of definition for a little bit. Would the definitional guidelines as you see them for pre-addiction be different for each substance? For instance, for cannabis use versus methamphetamine use versus alcohol use?
Yeah, that's a very good question, but and I'll extend it. Suppose you have one symptom that you meet for your marijuana use, another symptom you meet for your cocaine use, another symptom you meet for your alcohol. The answer is, I don't know. Those are very valid questions. That's the questions like that are part of the DSM right now. And if we move it lower, if we take the existing DSM structure the way of asking the questions and the way of counting the answers. I don't know how that will shake out, and somebody's got to start answering these questions because it's important. I have to say, I think it's particularly important with, I won't even call it marijuana, I will call it cannabinoid dependence. Most of the cannabinoid dependence now is in vaporized and synthetic, not the actual plant, but it's nonetheless very important. These early symptoms, particularly in people that have an other risk factor, are more, a couple of symptoms in a 55-year-old individual is otherwise stable are not the same as a couple of symptoms in an adolescent who's not doing well in school and has a very serious family history of mental illness. So again, I'm sorry, I don't have answers, but these are the questions that have to be addressed.
Kind of the point of research again, as you were talking.
Yeah.
Walters again says thank and appreciation for a thought-provoking presentation, but had a comment that I think is related to what you're talking about, which is this: now we've got so many substances, cannabinoids being one of them, but not the only one, that are being legalized or decriminalized. And does this have an effect on the predictive value of screeners that we might use to try to understand the issue of pre-addiction? And might it have more predictive value on illicit substances than more illicit substances at this point?
I'll give you a broad answer that, then a fairly specific one. Broadly, somebody in the UCLA history department ought to take a look at the concepts associated with what was considered addiction over the era. And it's fascinating. Even in my lifetime, there's been a transition from substances don't make you addicted. You have an addictive personality. That changed into, no, there are hard drugs that if you use those, heroin, methamphetamine, something like that, or if you use them via injection, well, then you get addicted. But otherwise, there are soft drugs. And with that, addiction was synonymous with physical withdrawal. That later evaporated, and currently the underlying concept, the diagnostic concept around which DSM-5 is formed, is loss of control, and that in turn can be manifest by any of 12 criteria. And I don't know, I'm sure this work is going on, but I don't know the research on which symptoms are most profound and earliest for marijuana versus heroin versus, mollies or some synthetic. I don't know the answer to that. And then finally, where I think it's all going is that it looks to me like the science is moving towards having addictions, substance use disorders, become part of compulsive disorders, where loss of control over your behavior, over previously regulated behavior, has occurred. In this case, as a function of regular substance use. In other cases, as a function of hand washing or gambling or internet or pornography viewing, whatever. Now, I don't know that that's going to happen, but that's what it looks like to me. And so the specific answer to your question is, yeah, it's going to matter. The right way to diagnose a pre-addiction, if you really wanted to do it, would be to measure some symptoms of current substance use, but in the context of family history, current other situations that are going on, depression, loss of job, et cetera, et cetera. That to me is the best, gives you the best likelihood of not only identifying a potential problem, but being able to look at the course of how that problem plays out.
We have a slew of questions, and I'm going to get to as many as I can in the time that we have left. But one more on diagnosis. Do you worry about the broadening the categories for diagnosis for kind of opening the floodgates, as it were? Now, all of a sudden, we lower the threshold and many, many more people need intervention services. And are we going to get an effect size that makes sense compared to what we're getting with people who have a much more severe sort of disorder?
So here's the very short answer to that. No, I don't worry about that at all. I mean, again, think about it. The reason you would ask that question is, oh my God, if somebody gets this diagnosis, they're going to be stigmatized. They're going to be labeled, et cetera. Okay, a reasonable concern. Weigh that against not doing a damn thing and watching somebody go from partying to regular misuse to early, to potentially catastrophic car crash or any number of things, to full-blown addiction. So no, I don't. Number two, another reason you would have that concern is if you're terribly worried about the financial health of our insurance companies, because the poor insurance companies would have to actually then, as it was true for diabetes, they'd have to open the reimbursement gates. Believe me, that's not something that keeps me up at night, okay? And so, no, I'm not worried about it.
Thanks. There's a growing body of literature, according to Kate Taylor, for CBT for specifically misuse, usually framed kind of in the guise of prevention, using CBT as a prevention effort. But to your point, how do we get those sorts of interventions that we know work on this category of individuals? How do we get them utilized in more real world settings?
Oh boy, that's a terrific question. Let me do partial justice to it. Number one, not only in addiction, but in any healthcare. I know this from my brief stint in Washington. You don't get the scientific treatment that is best suited or has been shown to be most effective in treating your condition. You get the care that has been advocated for and packaged in a way that is accessible and reasonably cost effective. It's a political cost negotiation, not a scientific one. So that's point one. Point two. Actually, would you clear sign of my age here? But I've lost track of. I was so enamored of what I was saying that I've lost track of the question. Say it again, please.
I've got to find it again. I'm sorry, I've lost track of it.
Oh, it had to do with CBT and and
how do we get them implemented in real world settings?
Okay, so that's what ultimately brings about new treatments is a negotiation, but a negotiation where somebody's going to make money. It's either a pharmaceutical firm or a behavioral health firm or a practitioner, or somebody's going to make it. This is America. Okay. Number two, the idea that we should move treatment forward, maybe through this concept of pre-addiction, maybe through some other way, that's hardly new. the prevention people have been saying this for a very long time. But here's the problem. Unlike the treatment field, there ain't no workforce. There ain't no site. There ain't no reimbursement, but no clear reimbursement for how to do it. If you drive down the road, you will see signs saying emergency room this way, hospital this way. There aren't any of those signs for prevention. So much of what I've been talking about could quite reasonably be called prevention, and in turn, CBT and CBT for CBT, the computer algorithm that's been widely used, ought to fill that bill. But it can't, because you don't get a reimbursement for it. It's not been packaged, it hasn't been delivered in a manner that's accessible. So yes, I think the treatment is the only area, the treatment infrastructure is the only area where I think it's likely to be able to get the money, the packaging, the access, the regulatory changes, the policy changes that will make new delivery of these kinds of interventions more possible, more accessible.
Thank you very much. We're almost at the top of the hour, and there's so many great questions. We've covered sort of all of the topics that are there, but there are many great questions that are left unanswered. I'm going to end with one, however, that I think is really important. You meet someone who clearly meets the criteria. They're misusing substances. They clearly meet criteria for something that we're now calling pre-addiction. Given the reinforcing nature of drugs and all of that other stuff, how do we motivate them to get some sort of services or intervention?
Yeah, that's exactly. It's one of the ones that are really on point. It's you are in a motivational struggle. It's partly a cognitive struggle. It's hard for people, especially early in the career, to say to themselves. I remember I had to work with the National Football League for a long time, and young, very athletic, adored millionaires that were smoking too much marijuana or using too much alcohol or both. It was just about impossible for them to believe that they could have a problem. So in those circumstances, you have to make something that's more attractive, but also fits into lifestyle. The best thing that I've seen so far, it's not good enough, but it's really very good, is contingency management. And it remains really remarkable to me that something as profoundly, that gets such a profound hold on an individual's behavior to the point that it's a compulsion, can be reduced with screwy little rewards delivered for behaviors that are inconsistent with using substances. So I think that tells me that it can be done. I don't think it's as effective as it may be. I think there are other ways, but there you go. I'll end with this. That's the right kind of a question. The question is, what can we do to change this behavior? I so much like that question over the one that I heard on my whole life is, well, it's up to them to change. When they're ready to change, when they are, then that is just 10 pounds of bologna in a 5-pound bag, okay? And it's been so harmful to our field, and it's perpetuated this delay into treatment. So I know that if Ford Motor Company puts out a product and people don't want it, they don't blame the customers. They invent a new Ford, and that's what we've got to do. Okay, and I think it can be done.
Dr.
End of speech.
Right at the top of the hour, and I really appreciate your time. Thank you very much for playing with me with these questions. I'm going to turn it over to Dr. Mooney to say goodbye.
Yes, thank you so much, Dr. McLellan, for such an interesting, thought-provoking, engaging talk, as evidenced by the numerous questions. We will be in touch soon. Thank you all for joining us today. Bye.
Nice to see you, Tom.
Great to see you.